that. So welcome back, and we're glad that you were able to join us for another virtual education session this month with a session that is focused on long-term care. My name is Kelsey Ostergren, and I am joined by the rest of the APIC's Great Lake Education Committee, Denise Parr and Chow Win. And as I mentioned, our session today is focused on long-term care, titled Preventing Resistance and Infections by Integrating Systems in Michigan, otherwise known as PRISM, a collaborative to improve infection prevention in nursing homes and enhance communications with hospitals. Before I turn it over to our panel of presenters for today, just a few sort of fundamental and routine housekeeping announcements. Please just make sure your line is muted. If you have any questions as we're going through the content for today, please feel free to use the chat box and we can revisit those questions at the end as we have time for Q&A. As always, the presentation will be recorded and will be posted to our APIC's Great Lake YouTube channel within the next week. So if there's content that you want to go back and revisit or share with colleagues, you can certainly do so from the YouTube page. And as we always do as well, the slides will also be available on our APIC Great Lakes website. There are no CEs available for today's event, but we are glad that you have chosen to spend an hour of your busy time with us today. So with that, I want to welcome our three presenters. First, Karen Jones. She has been an infection preventionist since 2009, beginning at St. John's Medical Center in Detroit, to managing grant-funded clinical research at the University of Michigan, to infection prevention clinical program manager at Wolters Kluwer. She holds a Bachelor of Science in Nursing, a Master of Public Health. Prior to IPC, she was an emergency department nurse in both Chicago and Detroit, as well as a forensic nurse examiner in Southeast Michigan, and has co-authored 20 peer-reviewed published papers during her career. Julie Scott and Randy Holland will be sharing their experience as IP participants in the PRISM project, so I'd like to welcome and thank both of them for being here. Julie has worked at DJ Jacobetti Home for Veterans in Marquette in the UP for 10 years, transitioning into her IP role, unfortunately, right before COVID in 2019. She holds a Bachelor of Science in Nursing from Northern Michigan and previously worked at the Marquette County Health Department. And then last but certainly not least, Randy Holland, who is the Infection Control Officer and Director of Ancillary Services at Hillsdale Hospital, located in South Central Michigan. He is responsible for IPC for Hillsdale's 47-bed acute care hospital, as well as their skilled nursing facility and outpatient clinics. Randy has a nursing background, holds an MBA, and is also certified in infection control. So with that, welcome to the three of you, and I will stop sharing my slides and let you guys take the floor from here.
Thanks so much, Kelsey. Let me pull up my slides. Well, good afternoon, everyone. You should be able to see my intro slide. Yes, thumbs up.
We can see him.
Terrific. Great. Again, thank you for joining. I was really excited to be able to share this 4-year-long project out of the University of Michigan that truly impacted many healthcare facilities here in the great state of Michigan. And also, I'm very excited to have Julie and Randy both on with me as co-presenters to be able to share their experiences in working with this initiative. All right, so who does not love a great visual abstract? Concise, to the point. This and the entire paper published in Clinical Infectious Diseases is open access, so it is free for you to view and download as many times as you want. What I'll be doing in this first about 20 minutes or so is to go over a little bit in detail on the methods on what we actually did with this project and a little more detail into our results. But as you can see here, the project, the 4-year-long project, was split almost down the middle into a pre-COVID and a during COVID timeframe, into those two timeframes. In the pre-COVID years, 2018 to 2020, we saw a 32% decrease in total infections in nursing homes, as well as a 63% drop in urine culture ordering. And we were so excited, so hyped up. We had great momentum, and then the pandemic. And you can see here on this infographic that we didn't see great results during the pandemic, but therein were lessons learned. So PRISM's design was built on a hospital nursing home cluster plan in which a hospital and 2 or more nursing homes that would often send their residents to these hospitals. The nursing homes would be receiving these patients as residents. There was a lot of that communication need and that sharing of patients. For them to be able to understand what the challenges were, both at the nursing home side, what was going on at the hospital side. And the picture on the right, we've got mapped out in Michigan, all of the nursing homes who participated in that 4-year-long project. Again, I'm Karen, Julie, and Randy. And just as a note, I'm currently a program manager at Wolters Kluwer, but we won't be discussing anything relevant to my role there. Julie and Randy have no conflicts of interest. Quickly for our objectives, I'm going to be reviewing the project, what we did, the recruitment, intervention, results, lessons learned, and then we'll have Julie and Randy further discuss and allow some time for questions. And this presentation is obviously not about me, but I did want to mention the transition that I had from 25 years in acute care, usually like a pretty intense setting, right? I love trauma. I liked my forensic nurse role in the Detroit area was very intense. And then going to nursing home settings, very, very different, right? But I thought, no, I wanted something new. I wanted something different. I'd worked with Dr. Lona Modi, who heads a lot of these projects at University of Michigan in a previous role, and thought, let me do it. Let me add it. So what did I find that was different, especially for any of you who may be faced with maybe something at your facility where you're like, do I want to keep going? Want to keep my infection prevention brain sharp? What I found going from acute care to an academic medical center or academic setting, because I did not work at the hospital infection prevention, I worked at the university. It was a very different mindset, but tons of resources, lots of personnel, lots of very, very, very smart individuals that could run statistical analyses faster than anything. And not to say that my group at St. John was not. We had a lot of fun. I learned so much on the job, and it really set the stage for me to be able to then go on and do other things like this project. And what the problem was that I believe that nursing home infection prevention was pretty much the same, right? Maybe it's a little more laid back, different population, but no, not really. And I had to add this picture in as I was looking back at some previous photos of my team at St. John. This was their going away cake for me, just to kind of underscore all the fun that we had and the relationships that I built with this wonderful group of IPs. And I think that can be said for a lot of our close-knit teams, both in hospitals and elsewhere. So what were some of the priorities that and common themes that these nursing home infection preventionists would bring up? Well, a lot of these items don't know boundaries within healthcare settings, right? So things like hand hygiene, infection surveillance, device use, surveyors, policy and procedures are pretty much universal concerns with infection preventionists. However, nursing home IPs also placed a high priority on things like hydration of their residents, which Julie is going to be talking about, communication challenges with their hospitals and other types of outpatient settings where their residents were being sent to, staff education, CNA education, CNAs or CNAs, as we might know them in the hospital setting, family and visitors. Um, CNAs provide a lot more daily care than nurses do in the healthcare environment in nursing homes, and that was a big priority for them. So just to give you a quick little rundown of some of the big other differences, that the length of stay are going to be very, very different with nursing homes. And just for that, it's going to change your risk assessment for what's important in infection prevention. So for a short stay population, which these are two separate populations, those are going to be your patients that are coming to the nursing home primarily for rehabilitation. Average length of stay is about a month versus your long-term care residents, which they're going to be usually living out their lives at the facility, is more like a couple of years. Although it's more of a home-like environment, there's going to be congregate setting areas. And then the services that are offered at the facilities are very, very different from one facility to the next. Some may do labs down the street. Others may have their labs sent out and won't get a result for a week. And it will be like in some sort of a faxed format. And then on-call providers versus on-site providers. That's very, very different from the hospital setting as well. And how are we determining by surveillance methods what is and what is not an infection? So I had to learn terms like revised McGear criteria, not an HSN, and then lobe criteria, which is not surveillance, but rather a clinical definition for what would indicate a likely infection, which would require antibiotic initiation for nursing home residents. But despite all of that, the goals remain the same: resident safety and infection prevention. So why should you, as a hospital IP or someone who's working in an outpatient center or a different type of clinic setting, why should you care? Because health systems are highly interconnected. So that means that a resident in a nursing home may likely seek out your care at your facility. And as health systems are highly interconnected, so is the risk of disease transmission. So partnerships really do make good things happen. As I mentioned, Dr. Lona Modi already, and actually she's been doing projects since before 2010. But she has been really leading the charge here in Michigan to support infection prevention practices and efforts across the state. And this little interactive map on the right, it looks like it's working correctly. You can see that over time, the nursing homes that have been engaged in some type of project with University of Michigan and Dr. Modi has really, really expanded throughout the years. This is a short list of some of the projects that she has led, some of the very high profile projects. You can use the link at the bottom of this page. It's not an active link right now, but it will be in some of the materials that you'll have available to you that you can see and access some of the publications related to these projects that she's done. And I know that many of you on the call today may have been participants in some of this work. One of the last ones that I did want to mention specifically and call out was our engagement with what was called the ARC ECHO National Nursing Home COVID-19 Action Network, or as we called it, MECHO. It was a very large nationwide initiative that invited all 15,000 or so nursing homes across the country to participate in a local collaborative. And what it did is it offered mentorship and easy accessibility to different types of resources in the midst of COVID. And in the middle of our PRISM project, we chose to become a hub, and we were able to do that work as well, along with PRISM. All right, so a paper by Dr. Modi published in 2018 in JAMA sort of set the stage for what PRISM was to be. And she described how integrating infection prevention programs could ultimately improve nursing home resident outcomes. So by doing things like sharing resources, we know that nursing homes are typically not well resourced, sharing that with the nursing homes, as well as sharing knowledge from the nursing homes to the hospitals. Learning about those unique characteristics of the facilities could really help to improve processes. So the project aims were developed to develop this type of integrated model, or these clusters. And then after we tested it out for 1 year, to expand it to 3 additional 12-month-long cohorts. Our goal was to enroll at least 60 nursing homes. We enrolled over 90 in our final analytic survey, or final analytic our final analysis. We included 63 nursing homes and 18 hospitals. And what we looked at were things like CAUTI, UTI, MRSA, C. diff, urinary catheter use, and urine cultures. And then we also wanted to get an idea of what our participants thought of this project. I'm not going to be talking too much at all about the qualitative results that we have with this project, but you can find all of that within the paper, as well as an additional paper that we published directly related to the surveys that we did. So this was the 12-month-long project timeline. And what we did before we started any of the meetings is we reached out to those hospitals. We started from the hospital side, and they provided us some local nursing homes. We also knew of some of the nursing homes that we had partnered with in the past, and we reached out to them. If a nursing home was in agreement, and the hospital as well, we had the nursing home complete a 36-question demographics and practice survey. We asked for previous year's infection data from the nursing home, but we rarely got anything that we could, successfully use or decipher, because their definitions were very different, and there may have been changeover. Records may not have been complete or accurate. So unfortunately, we were not really able to use that type of data. And then we identified roles and responsibilities, both from the nursing home side and the hospital side. So recruitment, I already touched on a bit. Typically, we would have infection preventionists, directors of nursing, administrators from the nursing home side. And then from the hospital side, we typically had buy-in from the medical directors of infection prevention and control, or the director of the IPC program. We also had quite a bit of interest from some of the post-acute care coordinators or directors in that role that really kept an eye on readmissions. The 12-month participation commitment basically just said, hey, can you make sure that you attend and participate in these meetings? And from the nursing home side, they also were asked to submit data monthly. I mentioned we had actually 92 that enrolled. We had 3 nursing homes officially withdraw from the project, mainly because that individual at the nursing home left and it was not able to be continued on. 9 nursing homes did not complete our demographic survey, and then 17 did not report at least 2 months worth of data. We asked for 12 months. So just some details on what our nursing home populations look like that participated in the project. Again, separated it out into our pre-pandemic phase where we had 40 nursing homes, and then our during the pandemic phase, which we had 23 nursing homes. Interestingly enough, the mean bed size was the same for each of those 2 blocks of time. We saw more for-profit nursing homes enrolled pre-pandemic across the country and also in the state of Michigan. The average about the number of for-profit nursing homes is about 70%. CMS 5-star quality rating, that's a measure that nursing homes are rated on. 3 is considered average, 4 is considered above average, 5 is excellent, so pretty good there. Full-time employees for infection prevention. Nursing homes reported that they had invested much more manpower into the IP role pre-pandemic, and those that were considered highly engaged in the project were hired during the pandemic, and that would consist of at least 10 months of data submission and attending at least 80% of the meetings. What did the nursing home IP experience look like? So the IP experience within the nursing homes. So before the pandemic, in blue, we saw that over a quarter of those IPs had been an IP for over 10 years. And then during COVID, it shifted a little bit. So that would be the yellow bar in this graph. We saw over 20% had been in that role for less than 12 months. So if we combine the 1 to less than 3 years, as well as the less than 1 year, we're seeing a large number of those nursing home IPs during COVID with very little experience. So we also asked the nursing homes, what are your top challenges at your facilities? The cohorts are listed on the left column, and then the number of respondents are in brackets. So what do you think? Any of you nursing home IPs want to type into the chat? What do you think is the number one challenge? It's not necessarily specific to infection prevention, but it certainly impacts infection prevention. Anyone want to hazard a guess? I'm checking the chat. Not being pulled to the floor, staffing. Carolina, you got it. Staff turnover, huge, really, really big. You know, it's important in any healthcare setting, right? Because you're continually having to do staff education, and it is going to be an endless cycle if you can't get that under control. So that was a common theme. So what did our in-person conferences look like? We held 2 large in-person conferences for about 4.5 hours long. We offered continuing education credits to nurses and administrators from the nursing home side. It was very interactive. It was a lot of fun. And then we also had in between those two conferences, which were held at project kickoff as well as the 6th-month point, cluster meetings where we would meet locally, usually at the hospital or someplace very local to the hospital. And it would be maybe about 2 hours long or so, but we'd always make sure that we'd bring lunch, giveaways, and we would share resources. We would have subject matter experts speak, and we would make it as brief as possible, right? We know that everybody's time is very short. And another thing, and this is based on some of Dr. Modi's previous work, is that it was very important to make sure that there was staff education that was interactive. So every time that we would have these in-person meetings, we would talk about and oftentimes demonstrate, as you can see in these pictures, ways to engage staff in making infection prevention education fun. So things like Family Feud, Jeopardy. Of course, you know, there's copyrights on all of that, so we'd make our own. We would use downloadable things from the internet. We also created something called the Wheel of Infection. So just making things really fun and as engaging as possible. So prison basics included making sure that our locations were convenient, thinking about those cluster hospitals, clustering things together, making sure that nobody has to drive a far length of time to be able to get to the in-person meetings, making sure that our subject matter experts were knowledgeable, were great speakers, were engaging, were open to questions. And then although we focused on UTI and CAUTI prevention, we listened to what the attendees really wanted to hear about. Nursing home IPs may have wanted to hear about water management, so we would have education on that. We also did site visits, and we did staff education while on those site visits at those nursing homes. We still have the PRISM Project website up. It has been archived, but you can still access the majority of the items that are on there. We had on-demand videos from individuals like Dr. Sanjay Saint, who helped us out with this project, and Dr. Vineet Chopra and Dr. Jennifer Meddings, a lot of really great, knowledgeable, experienced infection prevention advocates. And then what we did is we would offer all of our nursing homes a monthly feedback report. They were submitting their data. We would consolidate all of that, and then we would provide targeted and very specific resources to help them. And then we offered what was called a small test of change opportunity for nursing homes that went above and beyond. They grasped all those concepts. They were seeing some really great improvements. They had some buy-in from staff. We offered them an additional opportunity to create and implement and then share with their peers what we called a small test of change. So we were doing great, right? Our first 2 years, smooth sailing. We were seeing some great movement. And then the pandemic. So we were able to keep the project up and running by doing a few things. We adjusted our recruitment. As I mentioned, we got a lot of those nursing homes that had been engaged in the ECHO project. They wanted to continue the relationship that they had with us, but we delayed the start of our cohort 4 because it was smack dab in the middle of COVID. So we adjusted that. We expanded our meeting options. Now everybody's going to virtual. So we could also make some of our PRISM meetings virtual. And then we had support from our health department all along in the project, but that's when we really leaned on them to be able to participate in our webinars, to share their recommendations, answer questions. Every single webinar and virtual meeting, we would have them on to participate. All of this data is available within the paper, but just to highlight a couple of things, our nursing home infection totals, and you can see on the left column is why I'm displaying this particular table. We're looking at UTIs, non-catheter related, CAUTIs, C. diff infections, MRSA. MRSA is not lab ID for purposes of this project. We would probably have only a couple if we were just looking at lab ID MRSA events. So instead, we asked all for submission of any new MRSA infections, whether it be wound, blood, sputum, anything like that. So that's why those numbers are included and might look unreasonably high for a nursing home population. Then we combined all of those top 4 infections up there and put them into what we called a total infection composite. We also looked at the total number of urine cultures ordered, as well as the device days for urinary catheters. And this was our rates for those infections, as well as our urine cultures ordered, and then the p-value comparing pre-COVID and during COVID. You can see that the CAUTI numbers were low across the board during COVID, where we had pretty high rates during COVID, or before COVID, I'm sorry. Additionally, device utilization, pretty high during COVID comparatively, where device use was only about 4% pre-COVID in the nursing home participants, and it went up to almost 5.5% during COVID. And another way to look at it, so this graph represents the entire project. Cohort 1 is represented in red, the red arrow, blue for cohort 2. We saw a 32% decrease in total infections across those project years. And the arrow is pointing at the very beginning of the project for that 12-month period. And you'll see that there was no change during the pandemic. So cohort 3 started literally 2 days, I think, before the first COVID case in Michigan in March of 2020. And then we took that break. Cohort 4 started around November of 2021. No changes there. Urine cultures saw a 63% decrease in culturing for cohorts 1 and cohorts 2. We provided some really great resources that the nursing homes really enjoyed and took back to their staff, which made a definite impact. And then for cohorts 3 and 4, they started lower to begin with, but no real movement. And what about urinary catheter use? There was a decrease in cohort 1. Cohort 2 pretty much stayed steady. And then for our cohorts 3 and 4, there was an increase in urinary catheter use. However, there was no corresponding increase to our number of urine cultures ordered. So that we saw as kind of a win because we still promoted that. The small test of change, as I already mentioned, was kind of an above and beyond initiative that nursing homes could participate in. We saw 27 nursing homes participating in this additional small test of change, and it aligned with our PRISM goals, but it focused on things that were a little bit not out of the ordinary, but employed different strategies. So hand hygiene education, our staff from University of Michigan would go in with hand plates and we would bring everyone together. We would do some education. We would have them press their dirty hand on a plate. We would have them perform hand hygiene. Then we would take it back to our lab. We would let it grow. We would take photos. Everything would be numbered. We would return that information back to the IEP, who could then share that as a learning tool, in addition to other strategies. And another cool thing that we did within this was that we encouraged, and I think just about everybody did, for them to develop a short PowerPoint presentation and then subsequently share this information with their peers. We did, again, on that on-site education, and we developed a lot of additional resources and tools based on what the nursing homes were asking for. So to wrap it up, so I can let my colleagues speak, proactive engagement approach will impact HAI prevention in nursing homes. We did have qualitative data that really indicated a benefit both from the hospital side and from the nursing home side. Additional data indicates that more IP support is needed. There's more responsibilities, especially with COVID, continued high turnover, less experienced IPs, and frameworks like PRISM can withstand with backing from dedicated participants. Some of our additional collaborators in this work might recognize some of these faces. And Julie, I'll run your slides. You can tell me when you'd like me to advance.
Okay, you can go to the next slide.
You don't want to look at your face?
No, that's okay. So I am the infection preventionist at Jacobetti Home for Veterans. We're a 126 bed facility in the UP. Our members are made up of veterans and their spouses. And currently our census is 95% male and we're 98% veterans. The home was established in 1981 in the former St. Mary's Hospital, and we have 5 units. Next slide. So some challenges with our facility. Our building is dated. Also, it's a hospital that they converted into a veterans home. So it's not the most convenient when it comes to infection prevention. We only have 5 single rooms. We have our units, we have north units and south units. Our 2 south units, they're suites, which means the there's 2 rooms and they have a bathroom shared with 4 members. So that is a lot of fun when there's an outbreak. And then our population is 95% male veterans, so that can always be a challenge because they're very independent and know what they want to do and don't like being forced to do anything, like stay in their room. And then something interesting about us is we became CMS certified about 6 years ago, and we only certified 3 of the 5 units, and that's because of those south halls. Those, because they had the suites with the shared bathrooms, they did not meet the CMS regulations. So when we get our CMS survey, they can only go on our 3 units that are certified. We are VA certified though, and they do our whole facility. So we get surveyed annually by CMS and by the VA. But we do have a new home coming in summer 2028. They just had the groundbreaking for that, and I'm excited because they will all have their own room and their own bathroom. So next slide. That's just a picture of some of our members, just to kind of show you that we're really a lot of males. We have one picture of a female member there in the top middle, and she's a veteran. Next slide. I just threw this in there just because, like I said in the beginning, our building is dated, and it was a hospital built in 1955. So it does have more of a hospital feel than like a long-term care facility. So next slide. So why we joined PRISM. We had participated in the ECHO project in 2020 and 2021, and we felt that was very beneficial. We didn't want to see it come to an end. So we felt like when we learned about PRISM, that was kind of like a given. We were just going to move on with that. Plus, it focused on UTIs and COTIs, which is always something that needs help. So, so that was a bonus. We had the virtual meetings. We submitted the data monthly. They had a website. They provided lots of resources. And if we had questions and they didn't know, they were able to find information for us. And I attended as well as our administrator. Next slide. So we did an on-site visit. I asked Karen to come and do some education for our staff in regards to urine culturing stewardship. We were having our staff immediately going right to ordering a urine culture anytime a member had any type of symptom. So if they had a one-time episode of hematuria, they'd get a urine culture. And of course, those cultures 9 times out of 10 come back positive, and then they're going to have an unnecessary antibiotic. So she came in and we included all the healthcare staff, including the providers, RNs, our LPNs, and care aides. We had a good turnout and a lot of great feedback. Everyone enjoyed the education, and they were very complimentary, which does not happen very often at our facility. But they still remember the education because sometimes I'll refer back to that. So it really was helpful. So during the education, when Karen was talking about the importance of hydration to prevent UTIs and CODIs, they brought up hydration stations, which I'll talk about in the next slide. But we had removed those during COVID to prevent spread of infection, and staff were interested in the possibility of bringing those back. And since hydration is very important and it really does impact the urine cultures that we order, that's what I decided to do the small test of change project on. Next slide. So hydration stations are self-serve areas where members can help themselves to different flavored waters, juices. Like I said, our facility is pretty old and there really isn't anywhere that they can help themselves. So we set these up and we took them away during COVID because we were worried about spread of infection, which left members with no area to get their own fluids for themselves. So like I said before, you know, we have a lot of male veterans. They like to be independent. They don't like to bother the staff. So they're probably not going to ask for fluids unless someone goes in their room for another reason, then they might ask them. So the staff really wanted to bring those hydration stations back. So our objective was to increase fluid intake in our members by reintroducing the hydration stations. So I met with the dietitians, our dietary director, and some healthcare staff, and we re-implemented the hydration stations on one of our units. Next slide. So we looked at average daily fluid intake for 3 weeks prior to implementing the hydration stations and then 3 weeks after. And as you can see, they made a huge difference. There is a increase there in the first 3 weeks before implementation because while doing this project, we found out that some of the staff weren't documenting fluid intake for members correctly. So we fixed that as well. And then after we implemented the hydration stations, you can see it did jump up quite a bit. The members, they really enjoyed having that. They some of them would hang out there by the hydration stations. They always were interested in what would be there the next day. So next slide. So our results for average urine culture rate, we did see a decrease. So 2021 and 2022, the average urine culture rate was 1.19, and that was from data collected during PRISM. And then 23-24, using our facility data, we dropped to 1.06. So we did see a decrease in the urine culture rate. And then that graph just shows the monthly rate. Next slide. So what we took away from PRISM, one thing we did was we implemented the use of a UTI screener. So when symptoms, when a member may have a symptom like hematuria, rather than first calling the provider and asking for an order for a urine culture, they would start this UTI screener, which is in our EMR. And we would do that for about 2 to 3 days and try and encourage them to drink more fluids. Then we would see if their symptoms resolved or if they developed more symptoms that could be a UTI. So this really helped with the number of cultures. We utilized a lot of the handouts and educational material from PRISM. I even still use one of the videos that was really good about obtaining cultures. And then we introduced the hydration stations to all units after our successful small test of change project. And that's it. Any questions?
Thanks, Julie. I just wanted to chime in that, the issue with hydration is so relevant in nursing home settings, being that dehydration is a daily risk for many of the long-term care, in particular residents. And that can mimic things like, suspected UTI. If a resident has a change in mental status due to something like dehydration, maybe they can't voice their desire for fluids, or they've got a medical condition that requires additional intake, or a number of things, even the temperature, especially if it's an older facility, maybe the air conditioning is not as it should. Residents are much more at risk for dehydration. So hydration is super important. We'll have additional time for questions at the end. All right, Randy, you're up.
Thank you. You don't have to stay on this slide for sure. So I think I have like the best of both worlds with a lot of other viewpoints. I am the infection control person, department, the only one. So for our hospital, as well as our long-term care. So I see the hospital side of things and I see long-term care side of things. So our long-term care, we have a total of 38 beds in 2 separate units. So one unit is a 19-bed long-term care facility. The other unit is a 19-bed short stay rehab facility. Both of those are housed within the hospital. For our infection control budget, there's 0.5 that I'm budgeted to do long-term care, and then my other 0.5 technically is hospital, outpatient clinics, and everything else. When I was asked, I thought it was a good opportunity to learn more for our facility and get more education for our staff on long-term care to participate with U of M. Participated in the ECHO program and then went on into the PRISM program when asked about that as well. Next slide. So our focus in PRISM, we did very well initially. Did our urine cultures, as you can see, actually went down to 0 at one point. Our antibiotic usage went down and decided that antibiotic stewardship, as that was becoming a very important topic at the time, would be part of would be my small test of change project with the PRISM. What I noticed when our numbers started going up for urine cultures it was about that same time that we started having urology more involved with the hospital. So they were doing procedures in the hospital. So we were having more at facility consults from urology for our long-term care. And they were ordering more urine cultures. They were wanting more Foley's. So Foley days went up. They were and still continue to be not necessarily on board with all of the guidelines that are best practice for long-term care patients, as they are more outpatient focused. Next slide. So we are still doing fairly well with our urine cultures. Even before PRISM, we had 48-hour monitors that they had to complete before any urine cultures were submitted. We had a few of our hospitalists that also take care of our long-term short stay patients that were automatically ordering urine cultures, like Julie had said, with just one symptom or just one thing. Gradually, we've gotten them convinced that that's not best practice, so that is not the case any longer. I follow up personally with any urine cultures ordered that should not have been ordered. Call the physician. We still have posted on the units reasons for urine cultures. Our small tests have changed for the antibiotic usage. Had the 5 moments that are still on the units. We've had a lot of turnover in the last few years, so it's a continuous education process with all new staff. We've implemented all of this into our annual competency days, as we call them, when all of the staff have to come in and do checkoffs. What I've gained and what the facility has gained through doing all of this, I feel like, as a partnership with U of M and the knowledge that they have, it's also expanded to MSU and a couple of projects that I've done with them after this project has encouraged our administrator for the facility to look into grant projects to be more infection control savvy, I guess you would say, for our units. So we have received 2 grants now from the state. The first one, we implemented an electronic hand hygiene monitoring system for both of our long-term care units. That has been in place almost 3 years now, and to my knowledge, when we installed, we were the only long-term care skilled nursing facilities in Michigan that had electronic hand hygiene monitoring. I won't say the name of the system, but it is very cool for infection control. We average hand hygiene opportunities 11,000 a week that it monitors. Every staff member, I can pull up data that shows cross-contamination if they go from one room to another room without doing their hand hygiene. I have been able to use that a couple times when we haven't really had any serious outbreaks, but little 2 or 3 room people outbreaks, which is big for us, being small. given me the ability to track which employees have gone between those patients and where else they went. So it's pretty cool, I think, for us and for our residents and their families. This last grant that we received, we got UV continuous disinfecting lights installed in every room. So it has continuous UV disinfection. Just another level to try to help decrease the spread of infections or organisms growing in their rooms. As you know, we're not the only department struggling with turnover. Environmental services is like a revolving door these days. And then the last that we received, or that was installed with the last grant that we had, is got rid of all of the curtains in our resident rooms and have retractable screens. So they're vinyl. They pull out from the wall and have different scenery on them for the residents. And then they're able to be wiped down and then retracted back up to the wall. So very well for isolation rooms and just making sure I don't like curtains. I think they harbor a lot of infection and never get cleaned. So that's kind of what's been going on around here. And also these are a couple of pictures of one is the retractable screen and one of the images. Each resident that was coherent on our long-term care was able to pick out which scenery they wanted on their screen. And then the UV light is on the right. I don't remember if that's the last screen I have, but I would say the other thing that from doing this that has helped me as infection control, Aaron hooked me up, I guess that's how you would call it. So I'm part of an advisory committee with Laredo now, which is a global company that is best known for their mannequins for CPR, and they have different simulation things for nursing schools. So this is the first year that they're doing an infection control targeted workshop to try to figure out new things that they can produce as a company that would help anybody in infection control, hospitals, long-term care, whatever setting, like improve employees' knowledge. So that was another, just being part of PRISM, and allows me that opportunity as well. That's all I have.
That was a lot. Thanks so much, Randy. Just a little wrap up and some photos of the University of Michigan team and some of our partners throughout the years. I know we are pretty much at time, but if there's any questions, we're willing to entertain those. And we'll also be making these slides available. There's an additional slide after this with lots of different types of resources and links to items I may have referenced during the talk.
Thank you, Karen, Randy, and Julie for your time and presentation today. I do see 3 questions in the chat. So if you guys have a little bit of time, do you mind staying on and we'll just address these questions now? Okay, the first question I think refers to, Karen, the graph on the nursing home IP experience over the years from pre-COVID to COVID, and we see that decrease in the IP experience in years. So we're just wondering, if you guys investigate if this was new headcount that drove down the average IP experience age, or were there any other factors?
Oh, I just saw the question there. New head count. New headcount for the IPs.
Sarah, I wonder if you want to clarify your question.
There's also a graph that represents the number of years the IP has been working at that facility. I don't have that in the slide set today, but that's also data that's available if you look at the paper. If that's sort of what you're getting at, if like somebody maybe transitioned from a different role within the facility to the IP role, if that's. And that
Or
was,
Karen, yeah, wondering if, maybe like because of burnout, like during COVID, that folks are leaving, those with more experience in IP are leaving,
yeah.
um, like post, like during COVID compared to prior years. There's another question asking about, so Sarah says, I don't work in long-term care setting. I am inferring that one of the goals was reducing urine culture ordering due to over-ordering, and therefore maybe false positives. What were the stated reasons for over-ordering? Were catheter days assessed as a confounding variable for any reduction or increase in CAUTI rates?
Yeah, so a few questions here. Um, the ultimate, the objective right at the beginning of the project was to look at CAUTI and UTI overall. And we had not initially asked for nursing homes to submit their number of urine cultures, but we realized very quickly that that was going to be impacting what was defined as a CAUTI or a UTI, right? Um, so that's one of the things that we wanted to look at is overculturing happening at the facilities. And I think Julie described it quite well, and Randy as well, is that if there's just any symptom and there's not a process in place at the facility for ordering urine cultures, they're going to be ordered on anybody with mental status change. That's one of the most common things in long-term care. So identifying the um, reasons for why even the CNAs were, encouraging providers or, passing along that information that, yep, urine is malodorous, urine is dark in color. There was a lot of education that went into place along with that urine culturing stewardship piece of the project. Um, what were their stated reasons for over ordering? So yeah, that was I think the main. Julie, would you agree that those were some of the main reasons for?
Yeah, I think you hit most of them.
Yeah, and I mean we see that at the hospital side too, but I think it's buttoned up a lot tighter at the hospital side in nursing homes. There's a lot still to be realized and a lot of tools and materials that could be pushed out there to encourage appropriate culturing. Catheter days assessed as confounding variable. We have a lot of multivariable regression analyses done by Dr. Todd Green, who was the co-first author on this project with me in the supplementary appendices. So if you are a lover of data, I think you can narrow that down even by individual cohort to be able to see that.
Thanks, Karen. And then lots of positive comments and feedbacks in the chat that this was a great presentation. And Randy, I think there's a comment on how impressive it is that you guys were able to have hand hygiene monitoring and UV disinfection device. And wondering if the grant pay for these tools and platform every year.
So the install for the screens and the UV lights, that was a one time. That paid for the first 3 years for our hand hygiene monitoring system. So our contract comes up this year, which we will be renewing on our own. So at least it got it in-house for us. And just for our 38 beds, it's about 25,000 a year. So just it's a tool now that it's in place, has paid for itself, in my opinion, as far as infection control. And so with the R0 or the lights, they have a website that I can track the usage, but the cost of that annually is very minimal. So we pay for that ourselves. But a comment on the urine cultures, just real quick. For those that are not long-term care, urine culture, antibiotic, UA, all of that, long-term care has annual inspections from the state. So all of those are items that the state looks at and really, I don't want to say judges us, but we can get dinged for too many antibiotics ordered, doing urine cultures when they're not indicated, or so I think that was another reason that this was important to us that are in long-term care as well, to bring those numbers down to help with our state inspections.
Thanks, Randy. And then just one other question around hydration station. The question asked if anyone has tried or explored a product called Jelly Drops. Some other places have used cocktail carts for residents, which involves staff ordering beverages to everyone. So your process seems to have saved employee time for care and documentation. So Julie, I don't know if you want to comment on that since you talked about hydration station.
So our dietitian has looked at the jelly drops, and she felt like it wouldn't be a great product for us. But if anyone has used them and thinks otherwise, I'd love to hear, because I think especially on our memory care unit, it could be pretty helpful. She was thinking the amount of fluid that they're going to get from the jelly drops. So that's why we didn't go with those.
Yeah, and another thing that some facilities worked towards was to focus on bringing in more hydration-rich foods. So things like, I can't think of anything off the top of my head, maybe cucumbers. There we have a list, and actually one of our geriatrician presenters spoke about foods that are higher in liquid content, right? For those who may have residents who are more hesitant on drinking more and more fluids, they may be encouraged to perhaps take in more foods that have a higher liquid content.
Yeah, and Karen, did you guys explore to see if readmission to acute care settings decreased for those long-term facilities that implemented hydration stations?
Yeah, that's a really great question, and that we did not look at that within the study. We looked at a lot additional, a lot more features within the what the nursing homes did, their small tests of change, a lot of uniqueness within the facility types, again, that are in the paper, but that would have been something really interesting to explore for sure. And that is one of the reasons why initially the hospitals were on board with this initiative, knowing that readmissions are high in the priority list for hospitals. Good question.
Yeah. All right. I think that's all the questions in the chat. So once again, thank you to the three of you for your time and great presentation and collaboration among the work you're doing with nursing homes and hospitals within the state of Michigan. So thank you very much. And then with that, we just have some brief APIC Great Lakes updates and reminders before we start our peer-to-peer mentorship roundtable. So this is just showing our upcoming APIC Great Lakes webinar. So our next webinar is on Tuesday, August 12th, and that will consist of member presentations from National APIC this year. And then followed by October 9th is our APIC Great Lakes Fall Conference. So don't forget to register for that. And then November 4th is our last webinar of the year, and that it will be on Energeson Rebaseline, and that webinar is in the moment TBD. Next, Kelsey. Yep, so reminder of our APIC Great Lakes Fall Conference. It will be at the same location as last year, which is the Eagle Eye Golf Club and Banquet Center. And I believe the deadline to register is Tuesday, September 23rd. So if you haven't registered, please do so. And Kelsey just dropped the link for registering in the chat. And then again, if you missed the webinar, don't worry. We do have a APIC Great Lakes YouTube channel where all of these educational webinars are recorded and upload shortly after the conclusion of our presentation. So you can find all the recordings there, and then you can also find presentation slides and then any supplemental materials on our APIC Great Lakes website. And if you have any open positions or job postings that you need help filling, please send us an email at our apicgreatlakes@gmail.com, and we will get that job posting on our webpage for others outside of your team to apply for. And the link to the job board is also included and will be included in the presentation slides. And then with that, I am going to hand it over to Joe.